Okay, well, thanks everybody for coming. Smaller crowd today. I guess people are very busy on the ward. So thank you for coming and joining us for Grand Rounds. Today will be pretty informal. Today we're doing a journal club. And so Annie and I will be reviewing two articles that have come out in the recent months. The theme of it, both articles are themed around de-escalating care and deciding if patients are more inappropriate for outpatient care. And so we'll discuss kind of the patient populations and see if we think that any of these might be applicable to our patient population. So I'll be starting first. And so my article came out of CHEST just a few months ago, and it is discussing the management of low-risk PE patients and looking at whether or not these patients could be managed as an outpatient without hospitalization. Yeah, there's a few articles floating around if you didn't get a chance to look at them beforehand. We'll talk about them as well. So the main clinical question that was asked here was whether or not low-risk patients diagnosed with acute PE can be managed on an outpatient basis. As far as a little bit of a background, there are over 2,000 cases of PE diagnosed per year. Obviously, here at Mount Sinai, we diagnose a large majority of those at any one time on our services, both on ADS and on teaching services. The mortality rate can be very high, with up to a mortality rate of 17%. But for low-risk patients who have low-risk features, they actually have been found in multiple studies retrospectively to have a low mortality rate. And there have been some retrospective studies showing that they may not necessarily benefit from inpatient hospitalization and monitoring. And so this study was the first prospective study to look at patients diagnosed with QPE and being managed in an outpatient setting. And so the enrollment and capturement was from 5 centers, 1 tertiary care center, and 4 community hospitals. I believe this was done out in Utah, was the main area. Again, the study is a prospective cohort study. And the main inclusion criteria was that the patients were diagnosed with PE by CTA or by VQ scan. In addition, in order to meet the low risk category, the patients had to be low risk based on their PESI score, which is under a score of 86. And if you recall, our own PE protocol here does also risk stratify patients similarly as far as into the PESI score as part of that. So just as a reminder, these are some of the factors that are looked at as far as the PESI score. So we have things like age, sex, some chronic medical issues, and then their vitals and clinical status as determinants of their PESI score. So again, a score of 86 is pretty low. And so, already by age, that's already a high majority of the points. And so you can see that getting a score of under 86 is probably a little bit more rare for patients in our population, where we see patients in their 60s or 70s. But, we do see the occasional patients who are younger being diagnosed with PE who may have a low risk PESI score. As far as exclusion criteria, there were many kind of typical ones: pregnancy, age less than 18. If there were any features of a high-risk PE, meaning that they had sustained systolic blood pressure less than 90 or any sort of hypoxia, they were excluded. Any sort of hepatic or renal disease, any contraindication to anticoagulation, and then some more objective findings, whether they had a right heart strain on echo, if they had any evidence of other DVT, and also as far as socially, whether or not they would require hospitalization just because of various social reasons or lack of follow-up. So basically, all patients who qualified for the study, meaning that they were diagnosed with acute PE and were considered low risk, were observed in an ED or observation bed for 12 to 24 hours. All patients also in the study received a formal echo and also had an ultrasound done of both of their lower extremities, and if they had any other symptomatic extremities as far as like upper extremities, that was also scanned. The study designers also collected troponin and BNP. Although cardiac markers were not used as any sort of exclusion or inclusion criteria, they were used as more of a risk factor analysis later on. And so any patients who developed the exclusion criteria within the observation period were then disenrolled from the study. As far as anticoagulation, this was primarily managed by the ED physician. We'll talk about the results as far as what was the anticoagulation of choice. And then patients were arranged for follow-up with either a vascular medicine or primary care prior to discharge. And so the main outcomes that were followed in the study, the primary outcome was a composite of symptomatic recurrent venous thromboembolism, any episodes of major bleeding, or mortality within 90 days of the study. Secondary outcome was patient satisfaction at the end of the study, and they did this by use of a novel survey using a Likert scale. So, as far as the enrollment period, there were about 1,000 PEs diagnosed during the study period. Almost 4/5 of them were excluded for various reasons, including high-risk criteria or other exclusion criteria. A fair number of them also did not want to be part of the study and did not want to give consent, interestingly. And so finally, 213 patients did consent to the study, being low risk. And then 13 during the observation period ended up being excluded based on some of those exclusion criteria that I discussed earlier, which we'll go over during the results sections. So overall, 200 patients were evaluated for the primary outcome, which is a nice even number as far as statistical analysis. So again, looking at the patient characteristics, so you can see some of the patient characteristics. So again, as I mentioned earlier, the PESI score with a high proportion of the score being based on age alone. The age was much younger, interestingly, for patients who were considered low risk. Again, these are the low risk patients. I mean, there were a large group of patients who were considered high risk who were excluded. And so obviously you would assume that those patients were older. As far as any other interesting things here, there were a fair number of proportion of patients who had previous DVT, which is sort of interesting. And as far as biomarkers, so again, we also, during our algorithm, check biomarkers. And so these patients, tended to have a lower or negative biomarkers. And then as far as CT characteristics, you can see here that, there were actually a fair number of patients who had, pretty significant thrombotic burden. So you can see that they had bilateral PE was about half of patients. Main PE, which, here at our hospital probably would warrant, consultation with the PE team and observation just based on sort of the size of that. So there were, a fair number of those, and a fair number also associated with a pulmonary infarct. I thought this was a little bit interesting in that there was a fair number of patients who had subsegmental PE. And again, there is some thought now in the literature that these subsegmental PEs may not necessarily be as clinically relevant as far as actually causing symptoms, that sort of thing. Any comments or thoughts on any of the patient? Yeah, that was kind of interesting. These patients had previous history of VTE, but I guess had been stopped for some reason or another.
Overall, it's a fairly younger population with a PESI of 54.
Right, yes. Okay, so again, we sort of talked about the study enrollment. So as far as the primary outcome, which again was recurrent VTE, major bleeding, or mortality, there was only one episode of major bleeding that occurred during the study period, and that patient actually had like some sort of like thigh trauma from an accident, so kind of a freak accident, I guess, but nothing really spontaneous. And again, most importantly, no deaths or recurrent DVTs reported during the study period. This was not a primary outcome, but the study authors did note that 19 patients did return to the ED within 7 days of diagnosis for various reasons, and then 2 ended up being admitted. One was for pain related to pulmonary infarct, and I can't recall what the other one was for, but something fairly minor. I think he was having some chest pain and had like a positive chest test, so I guess maybe not minor. As far as the secondary outcomes, which was patient satisfaction, so about 3/4 of the patients completed the survey that they had done. You can see the questions there at the bottom that were used. And surprisingly, 90% of patients were highly satisfied by their initial care, meaning that they rated either a 9 or a 10. So clearly they must have a nicer ED than ours. Hopefully, no one's in the ED here, right? And then another question that they asked was, if they would prefer outpatient management again. And again, a large majority of them did say that they would be fine with being treated at home. Although again, note that as far as inpatient versus outpatient, I mean, the patients were observed in the 24 hours in the emergency room or observation room. So they did get a fair amount of hospitalization still. So some of the conclusions that were drawn from this study. So again, there was a low rate of adverse outcomes in low-risk PE patients, as has been seen in previous studies in the literature. Overall, patients were satisfied with outpatient management of their PEs. We can talk about this a little bit more, but it's a fairly generalizable patient population. Again, the catchment was community hospitals, a tertiary care center, and so probably not too dissimilar from what we're seeing here. And then interestingly, again, a lot of the older studies looking at low-risk PE and outpatient management were really done before the era of DOACs. And so here you see that there's a high percentage of DOAC use, and so almost 90% of patients were placed on some sort of DOAC for management, which makes things a lot easier as far as not having to do the whole heparin, warfarin, Lovenox, warfarin thing. Let's see. So as far as the limitations, so the patients did receive a fair amount of workup in their observation period, and so all patients did receive an echo and an ultrasound during the observation period, which again was 12 to 24 hours in an emergency room or obs bed. And as I mentioned earlier, about 10 patients did end up having additional findings based on the imaging that excluded them from the trial. And so these patients did find features which potentially would have increased their mortality risk and disenrolled them from the study. And so some things that we can discuss about, are which of these factors really most contribute to the low rate of adverse outcomes. And so is it more because they have low risk features? Is it because they had some workup which, showed that they did not have evidence of more significant physiological effect from the PE, et cetera? So this is when we'll open up for some discussion. And so some things that we can talk about here are, how quickly can we safely discharge patients diagnosed with QPE? We can talk a little bit about our own algorithm here. Which tools can we use to help us stratify our patients as far as when to decide how to DC patients? And how comfortable do we feel with the early discharge of patients? And so I feel like a lot of times we do get diagnoses of acute PE in the emergency room. And they may have like a small segmental PE, but are completely hemodynamically stable, but they still end up sort of being admitted by the emergency room. And so are those patients which may benefit from going to the RE2 or something of that nature. We have Hersher here as our one RE2 one of our one RE2 doc. And so do you guys get a fair number of PEs, or do they typically emergency room tends to just hit admit right away?
Once in a while, but it's not one of our more I think much more.
I just wanted to comment. One of the initial criteria for the hospital model was its low-risk BTD. So certainly, even maybe after a window period of BTD diagnosis, we would say that would potentially be a pathway, I think, in terms of admitting patients who still need some sort of monitoring.
Yeah.
But in the original studies, hospital home model BTD or low-risk BTD was considered acceptable criteria.
Is it currently on the list of diagnoses now? Oh, okay.
So we have an algorithm. I think Aaron was one of the people sort of developed that, right? The PE algorithm for home. I think
it was Trini was part of that. Yeah.
Okay. So have people been discharging folks home with PE? Yeah, good. And using the criteria that's on the card, has to be less than 5.
Yeah, I mean the algorithm that we have is pretty similar. I mean the only thing that really adds is the troponins and like the BNP, which I think throws them into the should get an echo before discharge.
Yes, I mean this for me it makes this particular study a little bit hard to generalize towards our population because we don't get an echo and an bilateral leg ultrasound for everybody, and I personally don't think it's really necessary. So I think that they screened out a really pretty healthy population in general. But it's for discussion if people think it's clinically important.
And the indication for the ultrasound?
So I think, right, so not really. I mean, it was, I think, probably more for the prospective component of the study that they did get all those imaging studies to sort of have that data. Again, only 6 patients had proximal DVT, meaning above the popliteal vein. And so those patients screened out of the study. But again, 6 out of over 200, was a fairly low number. And, whether or not that actually would increase your mortality risk is probably debatable. The authors had noted that there had been some studies suggesting that proximal DVT with concurrent PE is a little bit higher risk, which is why they were not included in the cohort. But yeah, if they otherwise have a low risk PESI score, then whether or not an ultrasound would really change your management, probably not.
And the concept of, by the way, early and late is a little bit artificial now, because before, early meant before you were therapeutic on your warfarin. Now, a lot of these patients are going in the hospital on, a DOAC, and now it's day 2, and they look better, feel better, but their PESI score was 93. Like, you're supposed to keep them there for 5, 6, 7 days? No, that's not appropriate. So that's where the early late comes from. It's now a little artificial if they're given a DOAC in the hospital.
Yeah, the whole point of the PESI is to not warrant the surrogate markers like echo and OTPMT. The low risk get those.
Right.
But only the limiting factor, I think, with the wax is whether or not you can get the patient approved from an insurance standpoint.
That's getting a lot better. Now is a lot. Yeah, I've been having a lot less viral trouble with the DOAC and coming through the surgery.
It depends on which one you choose, right? I think all those open right now, they have like some skinny display.
Oh yeah.
That was one question I would read. Did they get like the socioeconomic status or insurance status of the
They
patient?
did not mention that as far as what was the
If
population.
20% or 18.5% with isolated subsegmental, it might be worth getting a low risk drug to see if you even need to
In terms of the exclusion criteria, did they look at the bleeding risk? I forget.
They didn't look at.
Was that it?
No, they didn't look at anything as far as. I mean, there was a contraindication to warfarin, Lovenox, Xarelto, so that's kind of a relative contraindication. But they didn't use anything like the Has blood score or anything like that to help stratify patients.
I think the line hits on one of the key points here, which is the medicine works great, and we can usually pick out patients who are stable for discharge, but it's the same situation. Can they pay for it? Will they take it? Will they follow up? Do they know what to do if they don't feel well? I mean, if you can make yourself comfortable on all those points, then it's a safe discharge. If you can't, then you have to go and do it.
I mean, I think we're doing something very similar with our own algorithm, and so, I think the study just adds the body of literature saying that if they are low risk and they have low risk PESI score, etc., then they can probably be discharged fairly quickly after they're admitted. I think the only parts that we run into problems here, at least in my experience, is if they do have a very high thrombotic burden, and because we've had, you've certainly had your patients who've had like really big PEs that look really scary, but they're walking, talking, doing fine, but the PE team still wants to sort of monitor them just to make sure that they don't warrant anticoagulation or any sort of embolectomy. All right, any other thoughts? Okay, well, we'll move on then to Annie's article. Annie will be talking about antibiotics in infective endocarditis. So, Dr. Linger, thank you for presenting.
Okay, so I thought this article is sort of along the same lines of the idea of sort of what there is literature to suggest that like people sometimes do better at home, essentially, like putting it in a really summarizing that. But and I think now more people are looking into just are there certain disease states that can be like treated at home or perhaps like don't necessarily need the same treatment we've been doing. So multiple people have mentioned this like POET article to me, and so I thought it would be a good one for all of us to review because it's pretty new. So this is from the New England Journal from August 2018, and it's called POET, like partial oral versus intravenous antibiotic treatment of endocarditis. I think it's actually partial oral endocarditis treatment is how they get POET, but that's confusing. So the clinical so we'll talk a little bit about where they did the trial and sort of what the methods were like, but the overall clinical question that they were trying to answer is in patients with left-sided endocarditis, do they really need these very long courses of IV antibiotics, which often keep people either in the hospital or in facilities, in particular, like just the patient population that is at higher risk of endocarditis is patients who are using intravenous drugs, and that population of patients is a population you don't necessarily want to hospitalize at home with an IV line. And so they asked, is partial oral therapy, and we'll talk about what that means, non-inferior to IV therapy. So just a little bit about the method. So this was done in Denmark. So they say this is a national trial. So the entire country of Denmark has 5 million people in it, just like for some context there. So what they did is anybody who was diagnosed with endocarditis could be referred to this one cardiac center, which is like in a major hospital in Copenhagen. And they enrolled people sort of through that mechanism. So all of their hospitals are linked, so they could figure out, do we get everybody? So it was randomized, it was unblinded, obviously, and it was a non-inferiority trial. They were powered, their power calculation was that they would need 400 patients, so they stopped at 400 who had left-sided endocarditis. The organisms that they looked at were patients who had endocarditis related to Streptococcus, Enterococcus faecalis, Staph aureus. Of note, there's no MRSA in all of Denmark, so they had no MRSA endocarditis. And then coag-negative staph. And then every patient had had a TEE that was negative for abscess or acute surgical indication. So that was pre-randomization. And so what they did is they gave them IV antibiotics for like around 10 days. It was a median of 17, but it had to be at least 10. And then they were randomized into oral antibiotics to finish out a 6-week course, or IV antibiotics also to finish off a 6-week course. And their primary outcome was a composite of all-cause mortality, unplanned cardiac surgery, embolic events, relapse of bacteremia with the primary pathogens, essentially loss of source control, and they looked for 6 months since randomization. So it took them 6 years to enroll this many patients. So this is like a very busy part of the slide, but I just blew it up a bit. So this is the exclusion criteria, and I just think it's important to go over. So they looked only at people who fulfilled the modified Duke criteria. Excluded anybody with endocarditis related to any other bacteria. They excluded people with high CRPs, high white cells, or both. So essentially they all have like normal CBCs. Anyone who had signs of abscess formation were excluded. No TTE available less than 48 hours pre-randomization were excluded. Severely obese, so anybody with a BMI greater than 40, which in Denmark is rare. But I rotated at this hospital. So very close to my heart. But it is very rare. Anybody who had another infection that required intravenous treatment. They took out anybody who was expected to adhere to the assigned regimen, who had suspected reduced GI uptake, which meant that like just anything where they thought it would impair their absorption of the oral antibiotics. People who consent, who had planned heart valve surgery, impaired immune response, and then met other exclusion criteria. So they excluded a huge number of people compared to the number that they actually brought in. And then just a little reminder about the modified Duke criteria. So looking for just positive blood cultures with a typical pathogen, an echocardiogram with a vegetation abscess or a valve dehiscence, a culture that's positive for Coxiella burnetii. They didn't have anybody for that. And then just predisposing condition or IV drug use, fever, vascular phenomena, immunologic phenomena, or microbiologic evidence. So just a bit about the patient characteristics. The table is very busy, so I just took out the important stuff. So their patients were 75% men with a mean age of 67. In terms of the coexisting conditions, about 15% of the population in both arms had diabetes, 10% had advanced CKD, and then 7% had end-stage renal disease. 5% with COPD, 3% with like liver disease. It's not fully specified in the main article how severe, and then 8% with cancer. And then I talked about the pathogen breakdown. So their most common pathogen was strep, and then Enterococcus, MSSA, and then coag-negative staph. And then it was 50% were aortic valve, 33% mitral valve, and 10% were combined. And then there were a couple others that were like other parts of the heart affected. So before we go into the results, I just wonder how hearing who's involved in the study and sort of what their exclusion criteria were, like any reflections on just how this compares to our population, or like, is this reflective? Do we think of our population that we see in the hospital with endocarditis.
Sometimes we get young kids with endocarditis,
Mm-hmm.
but then they also probably so that's
Mm-hmm.
and in general, I think ours, looking at the close, I feel like ours are probably good.
Yeah, so a lot of their people, even who had coexisting conditions, only had one, which I think for us, we have a lot of people who have overlap of a lot of these conditions and like sort of are just generally probably sicker than someone who just has one of them. They have a very low rate of end-stage renal disease compared to like our population in the US who have endocarditis. And then, yeah, the no MRSA. So in addition to no MRSA, I'll talk a bit about the microbiology of their pathogens, but they ran susceptibility testing on everything. And they don't have very much resistance. Like their Staph aureus is like just sensitive to penicillin alone. So they're, in terms of their oral antibiotic choices, they may have some different choices than we would have here. Okay, so their results. So they found that the primary outcome occurred, this combined outcome, occurred in 24 patients. So it's 12.1% in the intravenous group and 18 patients in the oral group. So they were doing a non-inferiority study. It's not powered to find a benefit, but it was actually a lower rate of the primary outcome in the oral antibiotic group. And then this is just like the probability of the primary outcome like over time. And like, I mean, sort of you can see what they find. It's sort of the oral treatment stays below. And it seems like they kind of divide out at this 30 days since randomization. Okay. So we talked a little bit about how the population is talking over their population. So interestingly, part of the reason that they did this study is because there have been there's a lot of interest in the ID world in getting people into oral antibiotics versus IV antibiotics and for various infections. But it was a little bit hinky for them to assume that they could actually treat endocarditis in this way. So they did pretty in-depth microbiologic like testing of the organisms, and then they actually got, for all of the oral antibiotics that were used, they got serum drug levels for all the patients to make sure that the levels after a certain like number of days would be appropriate to actually assume that it's treating this infection at home. And they concluded that that type of testing, while it was interesting from a scientific standpoint, it's not actually necessary because they had 0 patients where they had to adjust any dosing, which is sort of interesting. Yeah, so how about just like initial reflections on their findings? It's like pretty impressive to say. I think the initial, so the way that this came out to me is I actually had 2 separate people say to me about a patient who had endocarditis with an organism that nobody had ever heard of. Like, oh, now based on the POET trial, like we could do oral antibiotics with like a susceptible medication. And so then I was like, well, I wonder if that's really true. And turns out it's like Aeromonas, and there's like no case reports of it being endocarditis, and we can't do that. But it was the same, 6 weeks. Yeah. Yeah, so they had to go to clinic 3 times a week to make sure they were still taking their medication and that they hadn't developed like any other concerning signs like or symptoms, like no return of fever, no murmurs. No.
They do symptom analysis. Because I feel like staff is a lot different.
Yeah. I think they did. I didn't include it in here. So, just to say, like, was it more or less effective? So it's a non-inferiority
all
study.
the bugs together.
Yeah.
It probably gives them more statistical power to group them all together. But
Yeah, so they did, and actually, so I didn't put it in here, but essentially all of them favored oral treatment. So this is like the plot.
Right.
It's actually it's on page 8, but like all of them are better with oral treatment. Yeah. I mean, so yeah, they don't have MRSA, but like we see enterococcus endocarditis. Yeah.
This was Denmark. I assume it's a fairly homogeneous group, like from a ethnicity, from a race and all that.
Yeah, they have a fair amount of immigration. I mean, they do have patients who are like not white, or who are not like from Denmark and have lived there for 1,000 years. But it is fairly homogeneous. It's more homogeneous than here.
Yeah. And you all have health insurance.
Yes.
Similar, probably similar.
They all have the same health insurance. That's why there are 0 patients lost to follow-up, because in Denmark people just track you. People are tracked from like the minute that they're born.
I guess the one thing is the population that it's hardest to do the IV antibiotics in, like the IV drug using population, is also the population that you wouldn't necessarily trust from what's in the world.
Yeah.
Also tends to have more insight on the
So I feel like that's really the group you would want to do it in, but then the question is how would you really make sure that they're
How many of these patients were IVDUs?
5 of 400. Not because they tried to exclude them out. Yeah. Yeah, I think that's a great point. So maybe like wouldn't apply to those patients. So like let's say you had a like person who had, let's say, diabetes and CKD, who had enterococcus endocarditis and was totally reliable. Would you use this to say, maybe I should consider outpatient treatment for this patient?
With an ID.
Yeah, no IVD.
with a very reliable patient?
Yeah,
I think so.
yeah. So I asked the ID division what they thought. Because I don't know, right? For some of this, like I'm just not sure. So they thought it was interesting. So I talked to, actually, I sent this out to a couple of people, and immediately multiple people emailed me back, and like clearly had a lot of thoughts about it. So it's ID week. Apparently, I think it's in San Francisco, and so they're all gone. But they said, these patients were all really stable clinically. They all had TEEs and showing no reason for surgical intervention, and we often don't get TEEs on our patient, and sometimes empirically treat them for endocarditis, where if somebody had like a huge vegetation, that you rely on the TE to rule that out. That's also different institutionally, but so for some patients, we like assume they have endocarditis if they're bacteremic. In any case, we often don't have that information to say like we're absolutely positive you don't need IV therapy. They had fewer comorbidities overall, and in particular, this like end-stage renal disease was concerning to them, and a very low incidence of IV drug use compared to our patients. There's no MRSA in Denmark, which like they were astounded by, and also felt like absolutely there's no way you can apply this information to MRSA. And then they also had like a lower incidence of MSA in the study population compared to the US. So in the US, about 40% of infective endocarditis is related to Staph aureus, and that's a mix of MRSA and MSSA. And so they felt like, this could have been in some part like driven by these other less common causes of endocarditis in the US. So to extrapolate it wouldn't be appropriate. And in particular because there are a lot more treatment failures with Staph aureus compared to other organisms, even for MSSA. And then I think that they took some, they were, I don't want to say frustrated, but they didn't really agree with including necessarily strep as a cause of endocarditis in this study, because in terms of the question that's being asked, those patients usually get shorter courses of antibiotics. So if everybody is on antibiotics for the first 10 to 17 days of like what would be in the US like a 2-week course, then you're not really asking the same question. You've essentially like given the appropriate treatment IV, but like saying that they do the same with oral antibiotics for 4 more weeks is like not really meaningful. And then their isolates are much more susceptible. So like for a lot of our patients, even who let's say have enterococcus, like a lot more of the isolates are more resistant and like have worse MICs in our population compared to theirs. So they said sort of like interesting, more research to come, don't change your practice pattern, feel free to talk to your ID consultant about it. Yeah. Or you could, yeah.
But I guess it does beg the question, if you have that non-IV drug use, non-end-stage renal, relatively healthy, stable patient who grows something that isn't staph, that is super susceptible and falls into all those categories, which is not that many patients, but
Yeah.
for that specific patient, maybe that's.
Yeah, it's interesting. So the patient I think where this came up for me probably and was relevant was a patient who many of you may know because she's recurrently admitted, but who had enterococcal bacteremia with a susceptible enterococcus and was sort of like, there was a big debate about even just for the bacteremia, could they do, and really like the reason you care about enterococcus bacteremia is in part because it can cause endocarditis. And so we had I had a discussion with Nicole Bouvier about, can this patient be on oral medications or not? Because otherwise she had to go to SNF, and without that she would just go home and like do her normal thing. And she felt very strongly about the IV ampicillin, and so she actually did end up going to a nursing home and then going home. But yeah, and something we may see more of, I think, especially is like we are having more people get acute care in a non-hospital place.
I think we all know it's pretty rare for one study to change practice. It's not like a 20,000 RCT.
Yeah.
It's a smaller one. Now, if the ID guidelines come out and say for super select patients with the right, MIC and home situation, consider it, then we'll probably consider it.
Yeah.
I mean, it may not be replicated. It probably needs to be replicated.
I think.
I was just gonna say, I see a glimpse of, or a fair number of patients with cardiothoracic surgery in like the evaluating for opioid treatment rule, and a lot of them would not have been included in this study. They get stuck here for weeks and weeks and weeks because no rehab will take them, and they don't want to send them out with an IV line. So it would really be very significant for the hospital if the study was not what it is.
No, but it does include IV drug users. They just don't have a high incidence of them. So IV drug use was not an exclusion criteria. Yeah, they just don't have a lot of people who do that.
Sounds like a love list. Are they hiring by any chance?
Probably. It's very nice there. They all speak perfect English. Yeah, their grammar was better than mine. It's very hard to learn Danish. You have to be fluent in Danish in order to work in a Danish hospital. It's very challenging. Okay. Thanks, guys.